Welcome everyone. My name is Kimsey Self and this is the Why Isn't My Digestion Working Part 1 class. This is actually part of a series. So you've probably noticed as part of the enrichment series, there's Why Isn't My Brain Working, parts 1 and 2. There's also coming out as Why Isn't My Immune System Working, Why Aren't My Genetics Working. So stay tuned, it's a theme and I try to get as comprehensive as possible. But nonetheless, I am going to go through, we have an hour and a half today to talk about all things related to specifically the upper GI tract. And I want to maximize that time as much as possible. So I'm going to spend the first couple of minutes just introducing myself so that way you guys understand who you're getting this information from, who's talking to you, and then we'll dive into the material. Secondly, I am a very participatory speaker. So do not hold back from raising questions, asking questions, raising hands, asking me to review something again, having comments or something that you want more information on as well. And vice versa, if I ask a question, answer it. Don't make me stand up here and talk by myself for an hour and a half. Okay. All right, as I said before, my name is Kimsey Self. I am a master nutrition therapist. I actually graduated from NTI about 5 years ago after fast tracking the M&T program. So thankfully, life lined up in a beautiful way and I was able to complete that 2-year program in about 9 months and then immediately got out and started kind of running with it. So since then I have completed numerous different opportunities for continuing education. And then professionally, I worked for almost entirely in the clinical environment. So for 2 different doctor's offices, one for 3 years, one for 2. And one was a chiropractic neurology, functional medicine office. The second one was largely integrated medicine. So this one was completely functional holistic, if you will. This one was more kind of a 50-50 split between Western and alternative approaches. And I was hired on for both offices for basically the same purpose, which was to help develop their nutrition and, using this term loosely, functional medicine program. So it was an amazing opportunity. I had the chance to form connections with supplement companies and lab reps and really kind of grow things up and do a lot more marketing, and it was an amazing opportunity. Since then, I have split off and started my own business, which is what Progressive Health and Wellness is. Progressive Health and Wellness is a completely virtual health and nutrition consulting and education business. So I meet with people via the internet, remotely out of their own living room, and I designed it that way so that I would not be bound by geography and the number of people that I can help. And thankfully, the model is working out beautifully. In that process, Progressive Health and Wellness's mission and purpose is to help as many people as possible find and experience true health. And I think we can all appreciate the fact that health is not just the absence of disease. It's also not limited to the physical body. So to honor this mission, having gone through this experience as a student myself, one of the best forms of education I got was going through this process on my own. Seeing a healthcare provider, an alternative medicine provider, and working out my own issues that brought me to the school in the first place. So if that resonates with anyone, I always offer a complimentary 25% discount on the first appointment, just to bring that up. If you want to take me up on that, just shoot me an email at any point. You all have my contact information, or talk to me after class. But it was one of the best ways to, once you go through it yourself, it's so much easier to relate to what other people are going through. All right. Digestive health was what got me into all of this. Basically, I wouldn't poop for weeks until I took something, to be completely candid. And I tried the pharmaceutical route and nothing worked. And doctors would never ask what I was eating. They would never ask what my lifestyle was like. They never asked anything. And it wasn't until I interned with Jess Kelly, who developed the oncology program, and started learning about all of the aspects of holistic nutrition that got me in. And I was like, oh my gosh, I found my calling, right? Everybody needs to know about this. So here we are today, 5 years later, and I'm still giving presentations on digestive health. So to continue looking over the agenda, First, we'll review a few statistics briefly, just so you guys understand the breadth of the matter. Digestive issues are extremely common. Most of you probably know that already, but we'll go over exactly how common. Then we'll go through the signs and symptoms of digestive dysfunction, take a trip down the gastrointestinal tract, roughly stopping at about the ileocecal valve, if you will, but obviously I'm going to reference the colon and whatnot too. Causes of dysfunction, we'll talk about hypochlorhydria, small intestinal dysbiosis, we're going to spend a lot of time on, and leaky gut syndrome. Really and truly, it looks like these are presented as separate things, but they're all intertwined. So that's why it's very easy to make this a cohesive discussion, because they all kind of lead into the other. And then lastly, of course, we will cover solutions, right? What can you do about it? So we'll go through antimicrobial regimens and detox support, and digestion support, diet, and intermittent fasting. And all of these, well, yeah, I was about to say something else, but that will cover us through the agenda. Part 2, if anybody's asking or wondering about that up front, why isn't my digestion working? Part 2 covers the lower GI tract. So for those of you, I mentioned that at the beginning of class, but for those of you that weren't here, it will cover the lower GI tract, primarily the colon, but then obviously you can't really separate the digestive tract. So we're going to reference the small intestines a little bit. We'll reference leaky gut syndrome, but for the most part, all of the testing references, for example, will really start to get into large intestinal health. Okay, statistics. First and foremost, let me give you some information. The Journal of Gastroenterology describes constipation or a component of irritable bowel syndrome if someone is not going to the restroom, having a bowel movement 3 times per day. Okay, so I'm going to put that out there right now, because most people are like, I go once a day and I'm good. That's not technically, according to their research, that's not technically considered optimal. And when you think about it, you think about how an infant goes to the bathroom, it kind of makes sense. Anytime you put food in your mouth, it's going to trigger peristalsis. Well, peristalsis is the same wave-like motion that not only propels that food from the esophagus down to the small intestine, but then also from the colon out until you defecate. So technically speaking, if you're eating 3 meals a day, you should be going to the bathroom 3 times a day. It's not super common that people come in to see me and they're already doing that. But I bring that up front because that might help some of these statistics make some sense. It will also help you look through a different lens for anybody that's actively seeing clients, or just if you came here for yourself, but to give you an idea, hey, that just expanded, I thought 50% of my clientele had a problem. Now it might be like 95%. So you can kind of start to look through it with a different lens. Okay, with that said, irritable bowel syndrome is extremely common. When I refer to irritable bowel syndrome, this is separate from irritable bowel disease, right? Irritable bowel syndrome is a functional disorder, meaning there's not anything anatomically, or there's no gross abnormalities associated with the intestinal tract. It is diagnosed specifically and solely based on symptoms. They just upgraded it to the Rome 4. It was, there's Rome 1, 2, 3, and now they're the Rome 4, which thankfully is actually a lot more comprehensive in its descriptions, its descriptions of the symptoms. But nonetheless, it is diagnosed completely based on symptoms. So we'll go over some of those signs and symptoms in just a minute. Keep that in mind though, irritable bowel syndrome, different. Irritable bowel disease refers to specifically ulcerative colitis and Crohn's disease. Those are both autoimmune in nature, and in that case, it is referring to an actual testable and pathological condition that's occurring in the intestines. Not technically, you could probably lump it in, but if you research irritable bowel disease, usually it's going to refer to those two, UC or Crohn's. Yeah, good question then. Okay, there are 3.2 million doctor's office visits per year associated with some kind of bowel upset. But the kind of ironic thing is 70% of people don't actually seek treatment. So there's a lot of people already. I think it was another statistic that I read is an estimated like 10% of the population or so has irritable bowel syndrome. But then when you factor in that 70% of these people aren't actually seeking medical care, it's probably a lot more than that. Clinically speaking, like I said, I see it all the time, either from a functional point of view or this is actually the reason that's bringing the person in. So it's extremely common. There are several different prescriptions that can address it, but none of them are really designed, everything from antibiotics to just stimulants, laxative stimulants, but none of them are designed necessarily to address the underlying cause. And oftentimes, I'm not going to bash on doctors at all, but oftentimes they're just not trained to identify the underlying cause of irritable bowel syndrome. So that's where we have a beautiful opportunity to work with these people because there's so much that you can do nutritionally. Okay. Also, just looking at it, anybody that's suffered from irritable bowel syndrome, it's extremely uncomfortable. It's not just limited to like, oh, I feel kind of full or, oh, I can't stop going to the bathroom. It can affect your entire physiology, right? You just feel toxic and heavy. And that explains why IBS sufferers are 3 times more likely to also miss work. So it can have a pretty big impact on quality of life, in other words, too. Okay. Signs and symptoms of digestive dysfunction, kind of working again from the top down. Start with heartburn or GERD, gastroesophageal reflux disease, which is basically just a chronic form of heartburn. Prolonged sense of fullness after meals, excessive burping, bloating, distension style or painful gas. We'll talk about why all of these happen as well. Foul smelling gas, very foul smelling gas. It's not normal, guys. I know that it's kind of become a laughing, a joke in society, like, oh my God, it's a room clear. But I would give my business card to people that do that, literally. Come see me and we'll clear that up because it's not normal. Constipation, diarrhea, bowel movement urgency. That's another one. Anybody, like you should be able to control it. If you have to go to the bathroom and there's not the opportunity, you should be able to hold it. If not, if it's like, oh my God, I need to go immediately, again, it's indicative of a problem. History of food poisoning, parasitic infection, or candidiasis. So this is really interesting, especially with antibiotic-resistant bugs these days. I'm hearing a lot more people that are getting food poisoning, which is traditionally just like a 24-hour thing, and then they're never really the same after that. So several months later is when they're coming to see me and they're like, I ate something bad and I got sick, but this is months later and I'm still not feeling well. So just bringing that up, that's something I've seen a lot more commonly too. Stool that is black, clay-colored, floats, or has fatty mucus streaks. All of those black typically means internal upper GI bleeding. If it's clay-colored, it's kind of like a light gray. If it's clay-colored, it's steatoria, so it's fat malabsorption. And fatty or mucus streaks, kind of hard to tell when you're looking at the stool to identify as fat or mucus, but nonetheless, it's either inflamed or it's not being absorbed or something's happening. Undigested food in the stool and many food sensitivities or allergies. All of these are some associated symptoms. Yeah. Clay-colored steatoria, it's fat malabsorption. So yeah, gallbladder issues sometimes or whatever, pancreatic issues. Yeah, sure. All right, let's take a trip down the digestive tract. So does anybody want to take a stab at where digestion begins? Mm-hmm. Good question. It's a trick question. That's a good one. Yeah. Technically the brain. So I say that because digestion starts with cephalic digestion. Yes, though, literally it starts in the mouth. Right? There's 3 phases of digestion. So we'll go through each of these. The first phase is cephalic digestion. This is the part that starts in the brain. Occurs before food ever enters the mouth. Simply smelling or anticipating food initiates the digestive response. This actually accounts for 20% of digestion. I want you guys to take that in for a second, because another way of looking at that is if you're not present with the meal. How many of you, I'm guilty of this, how many of you or how many of the people that you work with are eating while you're working, you're eating in the car, you're eating on the phone, you're eating with friends, you're not really paying attention to what's going on. Or in some cases, you're just full on stressed out and locked in sympathetic overdrive, right? In which blood flow is completely shunted away from the intestines anyways. In that case, you've automatically, right out of the gates, hindered digestion by 20%. So you're only operating at 80% capacity as it is. That's one of the reasons I bring this up, because that's a critical phase, and a lot of people live there. They don't even recognize it, and they live there, and that's how they eat probably 80-90% of their meals. Second phase is the gastric phase. So as the name implies, this is when the food you've chewed now, you smelled the food, you're getting really excited, then it comes into your mouth, you chew, it's mixed with saliva, amylase, and then you swallow. You want to chew, a lot of people say, chew your food 30 times. Just chew it till it's liquefied, right? For some people that might be 5, for some people it might be 150. Just chew it till it's basically liquefied and then swallow. Then it hits the stomach. This begins the gastric phase. Gastric phase occurs basically as soon as the stomach starts expanding. And the expansion of the stomach signals the pancreas and the gallbladder and the small intestines to also start releasing their digestive juices. So at this point, once it's in the stomach, ideally, it'll hit this nice vat of hydrochloric acid and pepsin, or it's being converted into pepsinogen. All of this is being released, and you start the chemical and mechanical digestion of food. So from there, it's broken down. It goes from a bolus into chyme. It's broken down in these tiny, tiny subparticles before it is passed on to the small intestines through the duodenum, and that is the intestinal phase. Now, almost everything in the body works on some kind of a reflex mechanism. So as soon as the brain, the nervous system, the vagus nerve, starts sensing that the stomach is expanding, A. B, when that acid hits the small intestines, both of those trigger the small intestines, the duodenum, the pancreas, the gallbladder, to release their digestive juices, bicarbonate splash to neutralize the acid so we don't basically incinerate, and then everything to continue breaking down that food into smaller and smaller subparticles, peptides, before it's passed through the 30, 40 feet of intestines by which we absorb. And we do most of our absorption in the small intestines. We'll absorb some B vitamins, vitamin K, some nutrients, and water in the colon. But for the most part, we're doing most of our absorption in the small intestines. Keep that concept in mind too. That's one of those kind of nutrition 101 things that, if you're anything like me, we often forget, like, oh yeah, small intestine absorption. Think about that, because if somebody's losing weight for unexplained reasons, if they're having multiple food sensitivities, if they have multiple nutrient deficiencies, it'll help point you in the direction of small intestine as opposed to large intestine, right? So some of these signs and symptoms can help push you into where do we really need to focus on, what might be happening. We'll go through a lot of that when we look at some of the testing examples as well.
How does that bicarbonate splash vary if you're eating plants?
Yeah.
You need a lot more acid to digest it.
Right, yeah.
So that buffering system, is that accounted for?
Probably, yeah. I think there is an association with how much acid is being produced so that the pancreas knows how much of the bicarbonate to release. So I would imagine it would probably be less. Yeah. With plants, yeah. Eating plants would be less. So another way of looking at that, if somebody has pancreatitis, for example, a plant-based diet, a vegan diet for a period of time to help them through that would probably be a good idea. Yeah, something to consider. Good question. Okay, causes of dysfunction. Now let's get into the nitty-gritty of it. So we'll start with hypochlorhydria, starting from the top and working our way down. So hypochlorhydria, there's also achlorhydria. Hypochlorhydria means an underproduction of stomach acid. Achlorhydria means it's inappropriately released, or it's not being released, but typically it means it's just inappropriately released, timing-wise. So most of you guys probably understand this already, that most acid reflux is associated with either hypo or specifically achlorhydria. It's rarely a problem of too much acid production. However, because we're not going to spend too much time talking about excessive acid production, I do want to mention that histamine cases, people with histamine sensitivity, or if they have bacterial overgrowth, like lactic acid producing bacteria, like lactobacillus, will produce histamine. You can have genetic SNPs in DAO or MTHFR or COMT. All of these can affect your histamine tolerance, basically. And in those cases, sometimes, because histamine is used to produce stomach acid, in those cases, sometimes if you're suspicious of a histamine intolerance, their acid reflux can legitimately be associated with too much acid. In which case, it kind of takes us down a different route, but not necessarily, because a lot of the recommendations and a lot of the things that we're going to talk about today can cause excess histamine, SIBO being a big one. So keep that in mind too. I don't want everyone going into, thinking acid reflux is only caused by too low of stomach acid. It can be caused by too high as well, or the stress response too, depending on, really that's more of an achlorhydria state though. Okay. What happens in hypochlorhydria is now that whole reflex loop that I talked about is interfered with. One thing to keep in mind too, yes, hydrochloric acid is important for digestion. However, it's also one of our first lines of defense, meaning if we eat a bad bug, let's pray it's killed in a vat of acid first before it gets down to the rest of the body. So if you're not producing adequate amounts of hydrochloric acid, you're also exposing yourself to potential infection. So keep that in mind also. That's the kind of the rule of thumb or the concept that we're going to piggyback on when we start talking about small intestinal bacterial overgrowth too, because all of these digestive juices second as antimicrobial defense mechanisms also. Bile salts, these digestive enzymes, even mucosal linings, all of these can second as ways to eliminate bad bugs and keep beneficial bacteria, their levels in appropriate amounts too. Okay, so continuing forward with hypochlorhydria, it accounts for partially digested large food molecules to then be passed to the small intestines. Not only does this place an added burden on the intestinal tract, so now the brush border enzymes, you have to release more brush border enzymes, and it's just more of a strain, more of work. But guess what loves partially undigested food? Yes, bacteria. So any bacteria, we naturally have, we have about 2 to 5 pounds of bacteria that live in the intestinal tract. About 80% of that is in the colon though. There's only supposed to be maybe a couple thousand bacteria in the small intestines. So they're supposed to be there, but just like geese at City Park, if you start feeding them, they're going to flourish and they're all going to come there. Same concept here. As soon as the bacteria become aware that there's more food there, some will migrate from the large intestines and then they'll just proliferate more. And so now we're getting into a small intestinal bacterial overgrowth issue. Some of the molecules in hypochlorhydria, some of the molecules are inappropriately absorbed while the others feed this bacteria. So it's kind of a double-edged sword. And then of course now we've got, especially when we've got, hypochlorhydria, the other concept too is that it's necessary for the absorption of certain vitamins and minerals. So specifically all of your B vitamins, calcium, all the big ones, calcium, magnesium, iron, zinc, all of those, you have to have the presence of acid in order to absorb them. That's why they came out with this quote unquote groundbreaking study last year or 2 years ago that said antacids are associated with dementia. Duh. I mean, come on. The effects that it has on B12 specifically is what that study looked at. If you're taking an antacid, you're not going to be absorbing B12, and now your brain is going to suffer amongst other things too. So malabsorption, vitamins, minerals, and proteins. And then with SIBO, with dysbiotic states, one of the seminars that I went to, the presenter worded it perfectly. He said that good bacteria eat our waste products and poop out nutrients. Bad bacteria eat our nutrients and poop out waste products. So it becomes this kind of burning the candle at both ends. Now we're missing out on nutrients and we're getting this toxic overload, right? So deficiencies, if you're noticing a deficiency in vitamins or minerals or protein, and we'll go over, I'll show you a basic complete metabolic panel where you can start to notice some deficiencies. The answer to a deficiency, sure, you can supplement for a period of time, but one of my mantras is you have to ask why until you can't ask why anymore. So are they lacking it in diet? Are they not absorbing it? Are they using it too quickly and they're not replenishing it? So you can start to identify where the root of the problem is, give them some of the vitamins so they feel better, and then address the underlying causes, a lot of which might boil down to hypochlorhydria. And then keep in mind too, it can become a vicious cycle. Like zinc, for example, you have to have zinc in order to produce hydrochloric acid. So this deficiency then feeds the problem, kind of thing. Yeah.
So if you suspect low stomach acid production, do you recommend like test, to see how it cuts in like one capsule, with
Meals.
high protein like each day, and you kind of get up to your like
Yeah.
dose and then back off one, or is there a better way to?
That's a great way to do it. Yeah, the first doctor's office I worked for, that's what we did with everyone as we gave them this test. So what she's describing is different supplement companies produce literal hydrochloric acid supplements. It's hydrochloric acid in a pill. I always use Metagenics Metagest. But what you do with that if you suspect hypochlorhydria is you have them take one like right before a meal, eat. If they feel this warming sensation in the stomach, they don't need the support. It's not hypochlorhydria. If they don't, then with the next meal you take 2. If they still don't, with the next meal you take 3. We capped it at 6, personally. Okay.
So like I got up to 6.
Yeah, gotcha.
So, like,
a lot of people were like that. Yeah. What we did is capped it at 6 and had the person take 6 with each meal until they started to, it's a self-eliminating supplement. So until you start to feel that warming sensation, when you do, take 5. When you feel it with 5, take 4 and slowly start to wean off of it. I would also suggest like really having them sit down with the meal, smell the meal, take 3 deep breaths and smell it to the point that they start to salivate. Once they start to, you can feel yourself start to salivate. So once you start to salivate, then eat the meal. And that can also help just to make sure it's not the stress response that's not allowing for the production of hydrochloric acid.
Are bitters something you can also take to help with that? Is that
absolutely? Yeah, bitters are great. Apple cider vinegar, all of those are great to stimulate that response also. Yeah, definitely. Sometimes depending on the person's presentation and if this is one of the primary things that we're going after, or if it's more secondary, depending on the person's budget, I will just use that. So I'll just use apple cider vinegar to help stimulate acid production, have them just swig it, 2 tablespoons roughly, but just swig it before each meal as often as possible. And or have some with water and lemon in the morning, first thing in the morning too, but swig it with meals also. Yeah.
I feel like you need all of that. I mean, maybe the apple cider vinegar, but like, would you really only want to do that for like animal protein or something, or even like if you're drinking a smoothie that has collagen in it, do you really need all that?
Yeah, good question. It's if it's just the vinegar, I'll have them do it before, kind of dose it accordingly, but do it before any meal. Just definitely with protein though. If there's animal protein. If it's the betaine HCl, I'll just have them reduce the amount. So maybe if they're having like an apple with almond butter as a snack, maybe they're just doing 1 or 2 pills instead of 6 that they would do with like a steak, if that makes sense. So just dose it accordingly. Yeah. And I know that, either way, you're going to have hydrochloric acid, even if you're just eating vegetables, It's just less. So that's why I try to do it that way too. Yeah, sure. That help? Any other questions? Good questions, guys. Good questions. Okay. Now let's move into small intestinal bacterial overgrowth. To give you guys an idea, I didn't even know about this when I was going through school. I just started hearing about SIBO like 3 or 4 years ago, maybe 3 years ago at this point. It wasn't getting a whole lot of attention or a whole lot of notoriety. But now it's one of those, like, once you become aware of it, it seems like it's everywhere, and that a lot of people struggle with it. So it's extremely common. It's pretty common to see. And we'll go over a statistic in a minute that'll kind of support that statement. But nonetheless, I mentioned we have 2 to 5 pounds of bacteria that live in the intestines. Most of them are supposed to be in the colon, some in the small intestines. We have built-in defense mechanisms to make sure that that balance stays appropriate. So there's several different factors, 2 of which we just talked about. The first one, hydrochloric acid. Sufficient levels of hydrochloric acid, not only will it make sure that the food is appropriately broken down, some of that acid, it affects the pH of the intestines, right? So all of those things combined will prevent the bacteria from either migrating up, or, we're eating bacteria all the time. You eat organic food, you're going to be eating bacteria. So it also helps prevent bacteria from coming in and just kind of taking up residence in the small intestines. Same concept with bile acid, bile salts. They will do that as well. They also have an antimicrobial property. Then we have the mucosal lining in the intestines. Mucosa is not just this thick mucousy stuff. It's filled with antibodies. It's filled with enzymes. It's filled with basically its own natural antimicrobials. So that will also help prevent the overgrowth of bacteria in the small intestines. And then from more of a functional, anatomical point of view, there's the vagus nerve and the ileocecal valve. So we're supposed to propel food from one end down to the other via peristalsis. And we have the migrating motor complex, which is the part of the enteric nervous system that is supposed to, when we're not eating in a fasted state, keep this in mind when we talk about intermittent fasting. In a fasted state, it propels waste products, cellular debris, old food. It's more of like a cleansing mechanism that propels all of that debris down from one end down to the other. So in other words, the nervous system is a big part of this as well. If the vagus nerve is not operating efficiently, if the thyroid isn't operating efficiently, because at the end of the day, the intestines are muscle. So if the thyroid's not operating efficiently, if there's anything that's affecting the transit time of the intestines, then that can cause this stagnation and allow these bacteria to build up. And then lastly, actually there was something else with the vagus nerve. Oh, it also stimulates the ileocecal valve and keeps the integrity of the ileocecal valve, that valve that connects the small intestines to the colon. So that valve is supposed to be, like all valves, it's supposed to be like a really, really tight rubber band where nothing gets through. It's one direction, right? Unidirectional, only goes this direction, this way. If the vagus nerve is not stimulating the intestines effectively, if you've got any kind of autonomic nervous system neuropathy, or even just functional, right? I'll show you guys some examples of how to test vagus nerve. If that's not working well, then this rubber band gets stretched out and then it kind of sits in this relaxed state and the bacteria can start to migrate up. So that becomes a major problem too. One test that I will do with people that I suspect this is happening, first and foremost, if anybody's locked in sympathetic overdrive, if on their intake form they rate their stress level at like an 8 or 9 on a scale of 1 to 10, you're probably going to have to do some vagus support and really get them to be present with a meal. We've got, and meditation, yoga, we've got to get them switching out of sympathetic into parasympathetic. Otherwise, those nerves are going to atrophy, right? If you don't use it, you lose it with the nervous system. Same thing happens with the sympathetic versus the parasympathetic. You can start to degrade those connections. So, couple of tests that you can do to determine the health of the vagus nerve. One, have the client lean their head back. You can do this to yourself too, but you'll need somebody else to look in your mouth. Have them lean their head back. You know the uvula, the arches and the little dangly thing in the back? Okay. If you say both of those arches, so if it's like these are the arches and this is the dangly thing, both of those arches should raise together and then come back down as soon as the person stops. So if it doesn't do that, if it does a variation of that, there's a autonomic nervous system problem. So if you say and it doesn't move at all, and one side moves, and it just moves and comes back up, any of these are a problem, right? So their vagus nerve is not stimulating that area appropriately. By the way, the vagus nerve innervates basically everything between here and here. So it plays a big role in all of this. It's also part of the autonomic nervous system. So that's one test. Second test is the gag reflex. So buy some popsicle sticks. You had them in a doctor's office. You do this on yourself. Gag yourself, right? It's a lot of fun. Stick it in the back of your tongue. See how sensitive your gag reflex is. If you're sitting and like digging around back there and you're not gagging, poor vagus nerve function, poor autonomic nervous function. If you like touch your tongue and then and immediately gag, if anybody ever says that they gag brushing their teeth, it's hypersensitive. So then the vagus nerve, those neurons are kind of sitting at threshold and they'll just go off with everything. Well, what goes up must come down. So typically they'll eventually exhaust, and that's where you start to get into more of like a vagus nerve fatigue state. You should be able to touch the back of the tongue. You have a little bit of a gag reflex and then pull it out and it's manageable, and that would be considered healthy. Not too much, Goldilocks syndrome, not too much, not too little. All right. Yeah.
And what do you do about that?
Yeah, that's where I was going to go next. Perfect. No, just in case. Yeah, good question. So what to do in that case is there's 3 different exercises that you can do to stimulate the vagus nerve. I'm going to say 4. The first one we've talked about, right? Meditation, active relaxation, be present with the meal. I can't overemphasize that enough. Do not eat until you're salivating. Okay. Second, gag yourself. So repeat that exercise and just keep a popsicle stick at your desk, in your car, and just sit there and stimulate that gag reflex consistently. Not if it's oversensitive. Don't do it in that case. If it's undersensitive, then just sit there and gag yourself. Second is to gargle water. So, and I don't mean just like, and then spit it out. Hold it for as long as you can. Hold it until your eyes are watering. Hold it and try to sing the ABCs. Do this for as long as you can. One way that you can do this is kind of tell the client as a reminder, basically anytime you go to the bathroom, try to gargle water. Just dip your head in the sink, do it for as long as you can, spit it out, and go back to work, go back to whatever you're doing. If you're sitting at home and working at home, just try to do it as often as you can. And then the third exercise is singing loudly. Your car is a great place to do this. If you live alone, then you're fine. Just do it as often as you can. Find some great songs and just belt the music. All of these technically target kind of slow twitch fibers and fast twitch fibers. So one is like doing sprints and one is like doing push-ups. So mix it up, but that will help stimulate that vagus nerve and then ideally strengthen it. That's the thing with the nervous system, right? You can regrow it. You can arbidize. You just have to use it. And then once your body feels that demand, then it will start to strengthen that connection accordingly. Good questions. Okay. Most of the time, that's going to be a component of SIBO. And when I use the term prokinetic, keep that in mind. That's what that is. And I'll talk about that with low-dose naltrexone. But prokinetic means getting something to stimulate the intestines and stimulate the nervous system. Okay. About 30 to 85% of irritable bowel syndrome, whether it's diarrhea, constipation, or mixed, comes down to a problem with SIBO. So if somebody comes in and they say, I'm not pooping or I can't stop pooping, there's a good chance it might be one of these. I'm not saying it is 100% of the time, but there's a good chance that it will be. So start asking about some of those correlating symptoms. You know, do you have acid reflux? Do you burp excessively? That's also a sign of indigestion. Do you feel prolonged fullness or an over sense of fullness after eating a small amount of food? Do you have gas and bloating, especially distension style bloating? Do you have partially undigested food in your stool? Are there nutrient deficiencies? You know, you can start looking into things like that too. Look at their fingernails, things along those lines, and kind of start putting together if this might be a problem. There is a test that you can run too. The formal test is hydrogen breath testing, which we'll talk about. I can usually get an idea if SIBO is occurring through a specific stool test as well. So sometimes I'll try to save the person money and just run one test that's going to give us a lot of information versus one that's very specific to this condition. But nonetheless, there is a test to rule it in or rule it out also. Yeah.
Are you talking about the lactulose?
Yeah.
Do you feel like there's a lot of false negatives?
I was going to say that too. Yeah, that's the other problem with it. There's a lot of false negatives. And then that one can be tough because, you know, the client thinks that they, you know, oh no, this isn't the problem. And you're sitting here like, oh, I don't want them to lose, you know, trust in the test, but you more than likely have it. There's a lot of false negatives for a few different reasons. Transit time of any kind. So if it's diarrhea dominant, and they have fast transit time, that can adversely affect the reading of the test. So it'll come up falsely negative. Sometimes usually the lab is pretty good at reporting if there's contamination in the test. It's a breath test. So you can imagine how hard it is to catch air, right? And sometimes room air will get into the test and artificially lower the results. There's a few different reasons as to what can cause false negatives. It's not the most sensitive. There is an aspartate test, but that's a lot more invasive. This is a home test. The aspartate test is where they actually go in and scope the intestines and take a sample from the duodenum of the acids. So typically you do it during an endoscopy when they're already in there, but that might be something, you know, if the person doesn't have insurance, good luck. And it's a lot more invasive test as it is too. So yeah, it can be false negative. Another way of looking at that is if they fit the clinical picture and they fit all of the symptoms. I've done it where I'll just move forward with the plan as opposed to testing. You know, you can look at food sensitivities and you can look at other things that might be affecting this. You know, maybe run a stool test instead, because even though that looks more at the colon, you can still get an idea of what's happening in the small intestines, especially from digestion and absorption markers. But usually I'll still move forward with some kind of a treatment, if you will. Okay. Yeah, I'm glad you brought that up too, because I had one that, I mean, I would have bet my career this woman had SIBO, all of the classic symptoms, prolonged history of it, ran the test, and that line was flatlined. I mean, not even detectable. And I was just like, oh, come on, you know, all right, fine, maybe not, but I still want to recommend this. So one other thing that's worth mentioning too, as far as, you know, symptoms goes, if you guys ever get those people, or maybe this fits you too, if you ever get those people that are like, no, I go to the bathroom, you know, 3-4 times a week, and that's normal for me. That's how I've always been. As long as I can remember, that's normal. Or I go 5 to 6 times a day. That's normal for me. Okay. What that means is that they've had a problem for a really long time. It doesn't mean that it's normal. It just means that it's been going on for a longer period of time. So don't be afraid to let the person know, like, actually, that's not normal. And we need to work on that. It just means that you're symptomatic and more aware of it. Okay, so classifications of SIBO. There's SIBO-C, which is SIBO constipation. Typically tends to be methane dominant. We'll talk about that in a minute. There's SIBO-D, which is diarrhea, and then SIBO mixed, which is both, right? Both constipation and diarrhea, high hydrogen and high methane. As you can see, it fits the IBS diagnosis too, right? There's IBS-C, IBS-D, and then IBS mixed. Okay, here's the mechanism. So these bacteria, just like you and I burp and fart after we eat, so do these bacteria. And they release specifically hydrogen gases. So they will ferment the sugars that we eat, the simple sugars. Keep that in mind when we start talking about FODMAPs. They will ferment the simple sugars, convert that into hydrogen. And that's one step. If that's happening, then typically, if it's hydrogen dominant, that's more associated with diarrhea, where they're having specifically issues with kind of chronic diarrhea. From there, there's this little interesting bug, I think you can hardly call it that, if you will, but they're called archaea. And archaea are fascinating. They live all over the place. They're one of the oldest organisms known. They live from in the depths of the ocean to volcanic matter. So they can live in practically any kind of environment. They are not bacteria. They're in a separate phylum. They're in a separate kingdom than bacteria. So what these are, they're single-celled organisms that eat hydrogen. So we start forming archaea around 3 years old. We're not necessarily born with it. But then they'll start to infiltrate just like everything else does. And so around 3 years old is when there's starting to be measurable levels of archaea. And archaea, when they eat the hydrogen, they then produce methane. And methanogens are what are organisms that produce methane. That's what they're referred to as. And the process of producing methane is called methanogenesis. So methane is the one that's more so associated with constipation type symptoms. If there's, and I mean, not to mention that, both of these gases will affect the production of short-chain fatty acids. So acetate, butyrate, propionate, those are some examples of some short-chain fatty acids. Short-chain fatty acids, there's still a lot of research being done as to what exactly they do for us. So far, I mean, they do have a function though. Butyrate, for example, is the primary fuel source for colon cells. So, we basically have a new intestinal lining every 6 days. So we have to have enough fuel to do that, and butyrate is one of those main factors. Nonetheless, the predominance of this bacteria or archaea, and if it's hydrogen or methane, will affect the short-chain fatty acid levels. We also absorb short-chain fatty acids. So that's one mechanism by how gut dysbiosis can have systemic impacts, is what are these short-chain fatty acid levels, how are we absorbing them, and what impact do they have at the cellular level. So that's why methane, as it says here, methane increases production of short-chain fatty acids and is linked from everything from gas and constipation to obesity. So it'll have systemic impacts as well. You can base, I bring this up also because you can get an idea on if SIBO is occurring and then which one it might be based on their symptoms. So if they're mostly diarrhea, it's probably a bacterial problem. If it's mostly constipation, it's probably an archaea problem. The biggest thing, and this is where the beauty comes in about nutrition, this is a study really quick that I'll let you guys read on your own time, where it actually starts to look at the connection between dysbiosis and obesity, for example. Okay, so looking at pharmaceuticals, this is one of the beauties of nutrition and antimicrobials, is because guess what won't work on archaea? Antibiotics, right? So antibiotics are targeted to attack bacteria, period, end of story. They're not going to work on viruses. They're not going to work on parasites. They're not going to work on yeast. They work on bacteria. They're not going to work on archaea. So if somebody's having a constipation dominant situation and you're suspecting that SIBO is the problem, save the time and money on rifaximin and neomycin, because there's a good chance it's probably not going to work. Now, can you still have an overgrowth? You can have mixed. And the rifaximin and the neomycin, rifaximin also goes by Xifaxan. It is an antibiotic specific to SIBO. So it's not as broad spectrum, and it's specific to these hydrogen producing bacteria. It's expensive as all get out. So it's over $1,000 for the prescription itself. Thankfully, because at the previous doctor's office that I worked for, they actually use this in a couple of people. And there's, if anybody comes and talks to you and says, hey, my doctor prescribed Xifaxan or rifaximin, through goodrx.com, you can find a coupon for literally $1,000 off. So the thing was like $1,200, and you can find a $1,000 off coupon, so it's $200. But nonetheless, these are, they're about a 10-day course. The studies vary on efficacy. I was finding efficacy rates as low as 10 to 35%, and then finding some that were higher, up to these 50 to 90% range. That was more so when rifaximin and neomycin were used together. One of the clients that I worked with, we'll actually look at some of his results. He did that round, and it did help. It did help. The biggest issue with these is, especially when they're just like, here you go, here's these antibiotics to, address this problem, but we're not going to look at hydrochloric acid production. We're not going to help you break down your food. We're not going to look at the stress response. We're not going to look at the autonomic nervous system. Then as soon as they come off of the medication, that foundation that allowed the bacteria to flourish in the first place is still there. That's why the recurrence rate is so high when you don't simultaneously address the underlying mechanisms. Yeah.
I feel like you hear all the time people do it, and then they feel right. They're like, oh my God, my world is changing.
So much better.
For like a week or two, and then like that really started.
Yeah.
So
Totally.
that's the scary thing about it. Is then you worry, have I done potentially good with this, or
Yeah, absolutely. That's often the case is it comes back, and it can come back pretty fast. Bacteria rule the world. They're going to replicate like that. So it'll come back really fast. And then, obviously it's not sustainable to just keep taking antibiotics. And for those that aren't working with someone that's experienced in addressing this, then, they're going to end up in this merry-go-round for a long time, unfortunately. The other aspect to this too that I forgot to mention is bacteria are intelligent, and they produce biofilms. You guys heard of biofilms? Some people have. Okay, biofilms are basically this protective sheath that many different organisms can produce. Bacteria, fungus, parasites can even produce them. It's this protective kind of force field shield that goes over their colonies, if you will, that prevents immunoglobulins from our own immune system, or antibiotics or antimicrobials from hurting them. So they're protected, in other words. That's another thing that tends to not be addressed, and that's part of what's fueling this antibiotic resistance is we're not addressing the biofilms. So take a bunch of antibiotics, it might kill off some of the bugs, some of the other ones are protected, those antibiotics go away, these bugs reproduce, and now we have a problem again. So as any part of any antimicrobial plan, at this point, I don't care if it's anything, yeast, small intestinal bacterial overgrowth, parasites, anything, include some biofilm disruptors in there. And there's a couple of specific ones on the last slide that I use. Proteolytic enzymes are really great for this. They essentially digest the biofilm, if you will. So proteolytics are great. Claire Labs Interface Plus is one of my favorites. NAC, N-acetylcysteine, is awesome for this too. And then you've got the concurrent benefit of glutathione production, in people that are able to do that. So that's a benefit as well. There's an awesome study, I don't have it in here, but I found it and blasted it out to the doctors that I worked with on the efficiency of NAC to actually break up biofilms in the cardiovascular system and in the heart too, because there's the bacterial component to heart disease. So yeah, so NAC is great as well. That's under the, I mentioned that here into the herbals and natural agents, but we'll talk about supplements a little bit down the line too. I have a protocol that I use at this point. It was developed by Metagenics, and I've been using it. I've used it on several people and get really good results and good feedback, and it's been really effective. And it's a protocol. It's 30 to 45 days you take this, and then 30 to 45 days we're going to rehabilitate the intestines and then move on. So it's not this let's drag this out for 3 to 6 months. It's a little bit more efficient, which is great. So that's what the metagenic Canibactin AR and VR protocols are. We'll talk about that more too.
So here you're still tackling SIBO, right?
Yes.
But really you should be tapping the biggest.
Everything during it.
So to stop the leaky colon. And then you don't have to do this.
No. So I would still recommend doing this, but while you're taking these, also take either hydrochloric acid or apple cider vinegar, also be present with the meal, also gargle and gag and relax and take digestive enzymes and all of it at the same time. Yeah, good question. Okay, the prokinetic I mentioned is low-dose naltrexone is the one that I'm familiar with. It's a prescription, so we're not going to be recommending this, but it's getting more and more notoriety even in the alternative medicine world. Yeah, absolutely. For cancer, for autoimmune, it's actually an opiate modulator. So it modulates the opiate system in the brain, and the opiates, endogenous endorphins, if you will, modulate the immune system too. So that's how it works. It has more of kind of a balancing effect on the immune system rather than just a suppressing or a stimulating effect. And it has this prokinetic property where it helps with the enteric nervous system, and it helps stimulate the intestines and helps keep the integrity of the valves as well.
Is that one the MMC or?
I think. I honestly don't know. I didn't see the mechanism, the exact mechanism on which part of the nervous system it's working on. That was just one thing that I had read under a lot of these studies with SIBO is use a prokinetic in this one, and that's how.
That's what they get the overdose.
Yes, yeah, because it'll block the opiate receptors too. So you can't take it with any kind of, what are those called? Like Valium or Vicodin or something like that. Yeah, you can. Benzos, yes, yeah, exactly. Thanks. Yeah. No worries.
Have you ever used or heard of using like 5-HTPs?
Sure.
Potentially, like there's a supplement with different populations, and it's like B6, ginger, 5-HTP, and something else in there.
Nice.
Just for like stimulating motility.
I mean, I don't see why not. I haven't done it, but I think it would be a great option. Sure. Yeah. Knowing, the impact that serotonin has on the gut. Yeah, for sure. That would be a great option. And, even people, you also get the benefit of supporting mood too, and the stress response and sleep and all of that also. So yeah, I think that would be a great idea. Sure. Yeah. Great question. Okay. Any questions so far about SIBO? We're going to keep going. I know I'm kind of flying through this information, so if you need me to slow down or go over something again, just let me know. Okay. So SIBO is the one condition where probiotics, for the most part, are contraindicated, right? Intuitively, it makes sense. You're feeding the fire. And oftentimes, oftentimes it's the good bugs, it's the lactobacillus of the world, the bifidos, that produce this hydrogen. So we don't want to add insult to injury with that. And SIBO is definitely associated with that histamine problem that I was talking about before, because a lot of those bacteria will also produce and release histamine too. So same thing, you don't want to fuel the fire by adding probiotics in. There are two kinds of probiotics that are, quote unquote, permitted, meaning they will help the problem. One of those is the soil-based probiotics. They are not fermenting. They don't have that same fermentation property, and they actually release these antimicrobial peptides that can be effective against methanogens. So they can really help with, like, the archaea, for example. I think it's VSL number 3, I think, is one that is soil-based or is permitted with SIBO. To be perfectly honest, I haven't really explored this route. Yeah.
What about probiotic?
I've heard of that.
So it's all bacillus. There's
Okay.
like 6 or 7 bacillus strains.
Yeah. Okay.
Apparently, those are also
Perfect. Who makes it?
Microbiome labs.
Okay. I'll have to check that out. Thanks. I was actually going to pose the question because I haven't used the soil-based ones. So that's good to know. Okay,
Yeah,
cool.
They say it's fun. So,
Okay. And what's it called again?
megaspore biotics. It's obviously
Spore, yeah. Megaspore biotics. Okay. Microbiome labs. Okay, cool. I'll check that one out. Yeah, definitely write that down. Thank you. I appreciate it. I use Saccharomyces boulardii. That's the only one that I've played around with. Saccharomyces boulardii is technically a yeast. It's a friendly yeast. It's actually a yeast-eating yeast. So it's good for also for like candidiasis states. Keep in mind too, we're limiting this to SIBO. There is such a thing as SIFO, which is small intestinal fungal overgrowth too. So that gets really fun and complex. I haven't necessarily looked into that one as much either. However, this protocol that I mentioned is effective against yeast as well, so it can be useful for both. And in that case, the Sac boulardii would be effective in that one as well. Saccharomyces boulardii is also used for people with traveler's diarrhea or just diarrhea in general. So if diarrhea is one of the main symptoms, it can help alleviate that too. Okay. No regular probiotics though, and in fact, for the people that take probiotics and feel worse, that can be one of the clinical indications that they might have SIBO. So if they, most of us, if anybody off the street was to come ask me like, hey, I have IBS, what should I do? I'd be like, take a probiotic. It's kind of one of the go-to steps for any bowel issues. But it's one of those situations, when you look back and if you only knew what you know now, you treat this person completely differently. Using the term treat loosely. But nonetheless, yeah, there were a couple people that I worked with. They were like, I'm getting a lot of gas and bloating and like feel worse with this probiotic. And at the time I was like, oh, it's die-off. It's die-off effect. You're fine. It's a good thing. But it might have been SIBO and it might have been actually perpetuating the problem. So just keep that in mind too for people that like, I stopped taking probiotics because I don't feel well on them, whatever it might be, then that should send off a light bulb in your head like, oh, do you also get these symptoms? And you can start steering down that road. Okay. All right. So must support the underlying causes. We talked about that. And then diet, we'll talk about FODMAPs and specific carbohydrates a little bit. I want you guys to understand the mechanism as to why these can be therapeutic diets. I also want you to understand why they're very difficult. So we'll talk about that and what that looks like as far as specifically FODMAPs go. Okay, let's switch gears a little bit and we'll get into leaky gut syndrome. I'm going to try, I think, first of all, has everybody heard of leaky gut syndrome? Okay. And do you all feel like you have pretty good grasp on what it is at least? Okay. So we'll, pretty new to it? Okay. Okay, cool. I want to gauge the audience and not talk about, rudimentary or way too complex of information and miss people. So leaky gut syndrome's been getting increased intestinal permeability. If you want to find any kind of valid research, search it by that. Don't go to PubMed with leaky gut syndrome. You can, but increased intestinal permeability is going to generate a lot more legitimate sources. It's been getting a lot of notoriety these days, and rightfully so. Even Socrates predicted that most disease occurs in the intestines, and it does. About 80% of disease is estimated to occur in the intestines through leaky gut syndrome. I want to present this in two different ways. One, when I was going through school, I left here thinking, everybody has leaky gut. Like, just treat the gut and everything's going to be fine, right? You have MS, treat the gut. You have RA, treat the gut. You have cancer, treat the gut. You have allergies, treat the gut. And you should always look at the health of the intestines. However, not everyone necessarily has leaky gut syndrome. And I don't want you guys going through what I went through, which is, oh, they don't have leaky gut. Well, what do I do now? Don't go through that. Right? But everyone, you're going to have to support digestion and absorption and the integrity of the intestines and bacterial balance in pretty much everyone. It just depends on how much and when in the process you do. So the other concept with leaky gut syndrome is if it is present, it's not this like Now you have it, now you don't, and you're good. It's this ongoing thing. So they're going to have to continue to support the intestines. It might come back and then it might go away, and kind of teach the person, and if it's you, teach yourself what your symptoms are. So when something goes awry, what are your body's little whispers to tell you, like, hey, something's not working well? Mine is digestion and sleep every single time. If I eat a food I shouldn't eat, if I'm stressed out of my mind, if something's not lining up, then my digestion is hindered and I don't sleep well. So I've started to recognize what those little signs are before they become these full-blown issues, and teach your people, teach your clients how to do the same thing, recognize the little things. Intestinal permeability being one of them. So to go over the basics, leaky gut syndrome, the first time I heard it, I thought it was absolutely disgusting. I was like, what is leaking out of the gut? But it's referring to the intestinal lining. So the mucosal, the epithelial lining specifically, and it's supposed to be a tight barrier. The intestines are one of our most important defense mechanisms and barrier systems. So it's supposed to be very tightly bound so that nothing can get through unless it's selectively escorted, in other words, absorbed through. That keeps, obviously toxins and cellular debris and pathogens in the intestines, which are technically considered part of the outside world. So the outside world is in the intestines as close as the outside world is going to come to our internal world, which is why that needs to be maintained. Through stress and bacterial imbalance and poor diet and food sensitivities, antibiotics, medications, several things can do this. The integrity of the intestines is lost. The integrity of that epithelial lining is lost, and it becomes more permeable. And that allows now these undigested food particles, microbes, toxins, pathogens to inappropriately leak into systemic circulation, which then triggers an immune response, and now we have a problem. So that's why, not to mention, some of these, whatever it is, toxins, microbes, pathogens, when they're circulating in the blood, if you think about it like an ant to sugar, yeah, I can email you about it. Have a great day. If you think about it like ants to sugar, they'll bind, the immune system, the antibodies will bind to this, and it forms what's called a circulating immune complex. So this guy circles around in your blood and can get lodged into different tissues, and then it stimulates the adaptive immune response, another branch of the immune system, to come in and kill it with chemicals, and this tissue gets lost in the crossfire. So that's where we start to get now either autoimmune conditions or pain syndrome, systemic inflammatory responses, something that originated in the intestines. Literally everything is being associated with this. Every kind of autoimmune condition, neurological conditions, psychiatric disorders. Everything in between. You have to look at the gut. So in my practice, the way I address it is, or approach it is, they have overt GI symptoms, we're going to start there. If they don't have overt symptoms, then we'll start later, but we're going to eventually look at the intestines, right? Okay, so there's a couple of ways that leaky gut syndrome can occur. Basically, it can be more permeable through the cellular lining or in between the cellular lining. So through the cellular lining is transcellular penetration of antigens. Between the cellular lining, these are called tight gap junctions. And you'll hear a lot about that when you read about leaky gut syndrome. These tight gap junctions, that's what they're called. If you think of them, think of it like a shoelace. So in fact, here we go. So in between those tight gap junctions, in between each individual cell, is an enzyme called zonulin. There's also occludin, which is a protein. And if you think of zonulin, and specifically zonulin, kind of like a shoelace, if it's not activated, it keeps the intestines, that wall, tightly bound, right? Keeps the shoe tied, in other words. If it is activated, it loosens it and allows it to open. They figured this out by studying cholera. So cholera has the same mechanism. Cholera also stimulates zonulin. So they've not only known this for years, it's so well known, they're starting to develop medications to induce this, hoping that it will enhance the absorption of the medications. I'm not going to get all political, but I think there's also ulterior motives, keep them sick kind of thing. But that's just me. Don't take the opinion. So, I mean, it literally predisposes you to so many other issues just to hopefully enhance the absorption of the medication. But point being, this mechanism is very well known. Well, what is one thing that stimulates zonulin? Gluten. Yes, gluten in, where am I? Everybody. So there's two responses that you can have to gluten. One happens in everyone, and one happens in some people. The one that happens in everyone is that mechanism. Gluten stimulates zonulin and predisposes you basically to leaky gut syndrome and a whole host of problems. It's more of a matter of when than if, question of when than if. The one that happens in some people is, on top of that, you also have an immune response to gluten. So that would be a gluten sensitivity. Not everybody has that. That kind of depends on the immune system. But did you have a question?
No, I'm just listening. I'm just wondering if this is like a physical break in test on it, or is this osmosis, or what? Is this actually a physical break in the intestine that allows proteins and whatever to get into the blood?
Good question. I don't, and this is what I explain to my clients also, I don't want you to picture like holes in the intestines. It's not holes in the intestines. This is very microscopic. So on that level, yes, kind of. Yeah, the physical integrity of the intestines is lost. But there's not like, holes per se in the intestines. It's also different. You're not going to get sepsis, for example, from this, meaning there's not overt leakage, cellular debris from the intestines in. It's these subparticles, very tiny subparticles that are inappropriately leaking.
Is this the lower intestine?
Upper. So leaky gut syndrome can happen in the colon, but it's more so isolated to more so involved in the small intestines. There, let's see if there's, weird. I thought I had it on this slide. Yes, it is phonetic. ZONULIN. Zonulin. So gluten, one of the worst things that we can eat, one of the most inflammatory proteins. I talk about that in the brain class also. I'll talk about it in the immune system class. Gluten, it's not the same thing that we've been eating, so whenever somebody challenges you and they're like, we've been eating gluten for years, why is it all of a sudden a problem? Because we haven't been eating this gluten for years, and we haven't had this technology, right? So gluten and the grain specifically that it's grown in is not genetically modified. It's a problem because it's been deaminated and hybridized. So hybridization is the process of growing certain plants together in order to produce certain qualities, right? That's where like broccolini came from. You grow, they do this with dog breeding too, right? You'll breed certain species together to get certain qualities. Well, they're doing that with wheat also. So we started with einkorn wheat, which is really ancient, and then slowly bred that with other varieties. And part of what they're doing is breeding it with certain forms of wheat they're trying to produce dwarf wheat, which is basically wheat that grows to maturity really fast, and it produces large amounts of gluten, because gluten is what gives, different baked goods their structure and stability. And it allows them to undergo a food manufacturing process and still maintain their form and shape and integrity, basically. So that's hybridization. However, that process, especially when you couple it with deamidation is mixing it with this enzyme acid mixture so that gluten can be water soluble. It's not normally water soluble. So when that happens, especially the combination of the two, it changes the protein sequence of gluten by up to 20%, which is pretty significant. So the immune system goes after proteins right? So now if you have this kind of essentially mutated protein, it's more immunoreactive. And there's different studies pointing at that, showing that it becomes this more immunoreactive molecule. And that is why gluten sensitivity rates are increasing. Also, I would have to say, with increased awareness, also increased testing, kind of a double-edged sword. But so use that argument. If anybody's like, gluten's a fad, it's not a fad. It's very real, and it's one of the worst things that you can eat. So I pull all of my clients off of gluten. I don't care if they're coming in for weight loss or stage 4 cancer. Every single person is coming off of gluten because it's really a matter of, like I said, when and if. Yeah.
And I feel like a good example of it is like people in Europe and they're fine.
Yeah.
And like they don't hybridize or I don't even know right.
No, totally. I agree. I totally agree. I was working with a woman who lived in, she was living in London, but she was from, I think, dang it, I don't remember where, Eastern Europe somewhere. And she was great. I mean, she, had a few symptoms here and there, but one of the things that she was the only person that I've tested. We ran Cyrex food sensitivity. I actually called the lab and was like, do we need to rerun the specimen? Because I've never seen this before. And they're like, no, we actually confirmed it. So it is, sorry guys, I'm having computer issues. Let me get this real quick. Okay. So it is a very real thing. And she even said, she was like, every time I come to the US, I get sick because of what she was eating. So yeah, I totally agree. Okay, so looking at solutions, testing is big. I'm always a fan of testing if the person's budget permits it. When I was working for the doctor's offices, and this is if you guys can get networked up with some physicians that bill insurance, and especially alternative medicine people that have these specialty lab accounts, like Genova Diagnostics, they're one of the main labs that I do a lot of GI testing through, and they have their own insurance billing program. So even if the physician you're working with doesn't bill insurance, they can still get the benefits through Genova's own program. But nonetheless, I say if their budget will permit it, because cash price can be kind of expensive for these. We're looking at between $200 to $500 for a hydrogen breath test and or a stool test. Nonetheless, there's the hydrogen breath test for SIBO testing, food sensitivity testing. Not all of them are created equal. There's the stool testing and then blood chemistry testing. And we'll I'm going to go through some samples of a lot of these. So Cyrex labs, I bring them up for a few different reasons. They're one of the leaders in immunological testing. Unfortunately, you have to have a license in order to work with them. So another reason to get paired up with a physician or a physician's assistant or someone, nurse practitioner that you trust and can help you with ordering labs. Nonetheless, they're leaders in immunological testing, and they have a lot of really great tests, right? Gluten testing specifically, I usually don't bother with. There's so many false negatives. I'll go through an example in just a second. There's so many false negatives because there's so many different components to gluten that it then gives the person artificial hope that they can eat gluten, and this whole problem. I'll show you that test in just a second. But Cyrex does also have this intestinal permeability testing. It's a blood test, and it measures the antibody response to different intracellular proteins and enzymes. So there's the actomyosin protein. Actomyosin, if that name rings a bell, it's because it's part of the musculature, right? Muscle cells. And actomyosin, if that comes back high, it indicates that transcellular permeability, where it's actually breaking through the cell, not just in between. So if you're forming antibodies to that, it does indicate leaky gut syndrome. It can indicate autoimmunity. I mean, technically, your immune system's launching an attack against cell tissue. Not all the time, though. If there's elevated breakdown of the intestines through leaky gut syndrome, your immune system's going to launch antibodies to that just as a process of ridding it from the body, cleaning up the cellular debris. But nonetheless, actomyosin is an example. Occludin and zonulin, those are the two that I talked about for the paracellular pathways. So if those come back high, you can deduce leaky gut syndrome. GI effects is a stool test. It's the most comprehensive stool test I'm aware of at this point. Through Genova Labs, you can also add on zonulin to that stool test and determine if leaky gut syndrome is occurring or not too. And then lipopolysaccharides. Lipopolysaccharides are they're part of the bacterial, I want to say exoskeleton, but kind of the bacterial cell membrane, if you will. And they're larger particles, they're larger molecules. So if those seep through into, remember this is a blood test. So if those seep through into the blood, then it indicates, this large particle is getting through, first of all. Second of all, there's potentially a lot of it, which means that there's a lot of bad bacteria. Lipopolysaccharides are extremely immunoreactive and associated with only the bad bacteria, if you will. Okay. All right. This is the gluten sensitivity test I was talking about. All of these, as you can tell, are real tests that we ran in the doctor's office. So like I said, I usually don't mess with gluten sensitivity testing because of the false negatives and because I don't care if you're not launching an immune system attack to it, I still want you off of it. So the last thing I want is, we run a test, it comes back negative, and the person's like, I can eat it. I'm like, no, you can't. And now you're out $250, right? So nonetheless, if for those persistent people that want to run a gluten sensitivity test, I would recommend this one. Wheat Zoomer is also apparently a good one, like a really sensitive one that we can actually get an account with. And that, oh gosh, I don't remember the name of the lab. If you Google Wheat Zoomer, Zoomer, it'll come up because that's the name of it, and we can get an account with them. But nonetheless, the one thing, so this test, the reason why is because, as you can see here, most gluten sensitivity tests are going to test alpha gliadin and maybe like gamma gliadin, two components of a very complex structure. So there's all of these different proteins or different components that the immune system can react to. And then you also have to, is it IgG mediated, IgA, IgM, like what part of the immune system is mediating this sensitivity? And that's the other reason I like this test is it's the most comprehensive gluten sensitivity test I'm aware of. The next component is these transglutaminase enzymes. These are indicative of celiac disease. So, well, I should say celiac for one of them, and then gluten autoimmunity for the others. So the tissue transglutaminase 2, tissue transglutaminase 3 and 6. 2 is, gosh, I always get these mixed up. I believe 2 is, here we go, celiac. Tissue transglutaminase 2 is celiac, so it's against the intestines, right? Tissue transglutaminase 3 is the skin, so it'll manifest as like hepatitis, hepatitis, the dermatological condition, these rashes. And then TTG6 is brain, so neurological
Those are all
disorders.
So MS. So what determines whether you get MS or it depends on where the protein resides. It's traveling through the blood and then it stops on your pancreas cells and your antibodies start destroying other pancreas cells or
Good question. So that part of it, these are only associated, the tissue transglutaminase, the enzyme is only found in certain tissues. So if the immune system is attacking that, that's what determines which kind of autoimmune condition is occurring. Not necessarily saying if you have TTG6 that you have MS. Not the same thing. In any kind of autoimmune condition, what determines where the immune system attacks Genetics are going to play a role in that. So if you have a history of RA, then like family history of RA, then more than likely it would manifest as that. Not always though. So sometimes it's that. Sometimes it's like molecular mimicry. So, the circulating immune complexes that I talked about, where those get lodged can have an impact in it too. If it's lodged in the thyroid, Hashimoto's, if it's lodged in neurological tissue, then, MS or many different autoimmune neurological conditions, joints, RA. So that can play a role with it. And the other thing too to keep in mind is many people with autoimmune conditions often have more than one. They might not be aware of it, but once the immune system loses tolerance for self, it's oftentimes not specific. So it'll just start attacking multiple tissues.
And it can change in one person, right? So I had a friend with the Hashimoto to fatty liver disease. So they're attacking various organs in the body, right?
Yeah, absolutely.
And why that changes?
I wouldn't say that it goes from one to the other. I would say it expands. So it was attacking the thyroid, and now it's also attacking this tissue. Not that it changed, if that makes sense.
That's pretty high probability of developing conditions if you have.
Yes. Yeah. There's a good probability of it. Not in everyone, but there's hundreds of autoimmune conditions. We've only named so many of them. But technically speaking, the immune system can attack whatever it wants to attack. This lab, Cyrex Labs, has one of the best autoimmune tests out there. Cyrex, it's Array 5. It's their multiple autoimmune panel, and it tests 24 different autoimmune conditions. So 24 different tissues, in other words. That's an awesome test if you suspect autoimmune condition in someone. Yeah, good questions, guys. I will say we're at 1:30. We have just maybe 10 more minutes if you guys are able to hang in there. If anybody does need to go, though, please feel free to excuse yourself at any time. Okay, this is an example of a food sensitivity test. I personally use MRT, which is mediator response testing. What I meant when I said that not all tests are created equal, antibody testing, most food sensitivity tests will be like IgG or IgA, sometimes IgM. IgE is different. But the problem with antibody testing is it's not very sensitive, first of all. Second of all, you'll form antibodies in a healthy response just as a means of clearing out debris, right? So just because you have a mild IgG response to like almonds, for example, you have to go with the whole clinical picture. Kick out almonds for a period of time, 2 weeks, and then bring it back in. Do you notice anything? It can be a healthy, normal response. So because of that, I prefer to use either this or ALCAT, which measures a white blood cell response, specifically measuring cytokines. So mediator response testing measures those cytokines. You've got a food, and then you bind an antibody to it. Antibody is just a tag. It just says, come in and destroy this. So when another branch of the immune system comes in to do that, it either engulfs it, like phagocytizes it, and destroys it in vat of acid, and then releases all of these other chemokines to attract more immune cells to the area, or it destroys it with chemicals, cytokines, and it destroys it with chemicals. And this test measures those chemicals. So in that case, we know it's launching an attack. It's not just trying to clear it out. It's actively launching an attack. And clinically, I've run this on myself. I've run this on a lot of clients and get really, really great results when they eliminate these foods.
Does that mean you have a leaky gut, though, if you're sensitive to?
Not necessarily. No, not always. You can still have food sensitivities and not have leaky gut syndrome. If you have a lot of food sensitivities, it suggests that leaky gut syndrome is occurring, but again, not necessarily. The other thing with leaky gut testing too, and the reason I kind of vacillate back and forth on this is I essentially kind of look at everyone, depending on their clinical picture, as if they probably have it, and I quote unquote treat them as such. Because leaky gut testing, it's not like zonulin, includin, and actomyosin are the only proteins that regulate the intestinal lining. So there's more than likely several other proteins that we're just not testing right now that are associated with this. So if it comes back negative, If it comes back positive, you have it. If it comes back negative, you probably don't, but you might still. If that makes sense.
So after you take a food out that you're sensitive to, and you reintroduce it and you feel okay, is there a need, I mean, should you go back and retest just to be sure? Or?
Yeah, great question. It depends on the person and it depends on their finances. And I typically allow them to dictate if we retest or not. So I don't normally. I'll just have them rotationally introduce that back in so they can start eating that food once every while. Specifically once every like 4 days. Some people want to retest. And in that case, if you want to retest, then I'll never say no. I'll never turn that down, but I won't necessarily require it or suggest it. Yeah, good questions. All right, keep trucking along. Stool test. I'm not going to go through the stool test in depth because this conversation is geared towards small intestinal examination. But when I said that sometimes I can deduce if leaky gut, if SIBO is occurring through a stool test, this is a classic result of why. So we ended up running a hydrogen breath test on this person too, and it was raging. It was classic SIBO. But nonetheless, honestly, I would have looked at this and probably not even suggested a hydrogen breath test. What I'm looking at is these are healthy cohort results as far as amounts of bacteria. This is the patient results. So as you can see, he has an overgrowth. He has a lot more than what is deemed healthy by research. So that in and of itself, he has intestinal inflammation. EPX is released in the small intestines. He has digestion and absorption insufficiency with fat malabsorption specifically, and he has hypochlorhydria and low short-chain fatty acids. So all of these, the other thing with the fat malabsorption too is in SIBO, some of these bacteria will actually eat bile salts. So it can lead to fat malabsorption. So his symptoms were gas and bloating and painful distension and IBS and acid reflux, and he was textbook for this condition. And so that's what I mean. Plus with the stool testing, like this specific test, now you're also looking at the colon and digestion and absorption markers, and you're getting a lot more information than just SIBO, just hydrogen breath testing. So that's why, especially for a limited budget, or sometimes what I'll do is start with this. And if it comes back like this, I'll just assume SIBO is happening. Sometimes we'll run the test also. Some people come in and they're like, I want all the testing. So we'll do that too. But this is an example of how you can kind of start to see patterns in things without explicitly running the test. And then one other, this is a complete metabolic panel and complete blood count. The reason I bring this up is because I just wanted to show, remember, you have to have hydrochloric acid in order to absorb certain nutrients. So in her case, when you look at total protein, iron, magnesium, and ferritin, and calcium, she's low in all of them. And all of those, you have to have hydrochloric acid in order to absorb them. So it fit, right? It made sense where I'm looking at this and I'm like, you probably aren't digesting well. And of course her bowels she tended more towards constipation and they just weren't regular. Sometimes she would get all of it, sometimes not really. She was averaging 1 bowel movement per day, but often kind of still felt backed up. Her chief complaint was actually bipolar disorder. So a little bit different, but we treated the whole thing, the whole picture. So, and when I say they're all low, I'm referencing the functional range, not the lab reference range. So some of these are flagged lab low or lab high, but I'm specifically referencing the functional range. And that's part of what allowed me to put together that picture.
Did you diagnose her as bipolar, or are you allowed to do that?
Yeah, no, we don't diagnose. Yeah, no.
Okay, so she came to you and said, I think I have bipolar disorder. I could diagnose it that.
For years. She had been diagnosed for years, and it was severe. It was pretty severe bipolar disorder. She had been medicated for about 20 years also, and that was one of her goals, was to come off of the medications. But we identified several different things that were leading to her bipolar disorder. One hard thing about that population is compliance, meaning it takes a lot of work, and they can have a hard time sticking with it. She was great. She really did what she could. And we addressed this, took her off of gluten, dairy, soy. She was having like a soy latte every morning and eating a bunch of corn and dairy and gluten with everything. And had MTHFR, and she had several things going on, and she did start to improve. But finances were also a problem, and so there were just kind of some things that came in between. Yeah, but not while I was there. She was still a client sporadically when I left, but I was working with one of the doctors. She was seeing one of the doctors in order to help with the titration of the medications. Not doing that. Especially with psychiatric meds. Yeah. So, what was I going to say with her though? I don't remember. But that was one conversation that we had, was looking at this, and we supported her digestion and tried to get that moving too. All right. So diet. We're going to breeze through diet a little bit. The reason why. So diet will always want it to be anti-inflammatory, always low glycemic. Paleo is often a great starting point for people with these conditions. I mentioned FODMAPs. So FODMAPs, fructo, oligo, di, mono, and polyols. So they're the simple sugars. That's what FODMAP stands for. And it's those sugars that these bacteria can ferment into hydrogen. So the concept is you starve them. Here's the problem with FODMAPs. Two things. One, it's a lot of healthy foods that are eliminated. So broccoli, Brussels sprouts, onions, garlic, a lot of healthy foods are eliminated. It's a very restrictive diet, in other words. More importantly, the problem I have with FODMAPs is I can't for the life of me find a consistent source. So one site says these are okay, the other one says this. One resource says these are okay, the other one says this. One says this, one says that. And and I'm not going to deal with people emailing me saying, hey, I found a resource that says I can eat avocado. Hey, I found a resource. I'm just not going to do that. So, and not to mention, if it's confusing for me, it's going to be confusing for them. So all things combined, personally speaking, now I'm not saying I'm an expert on FODMAPs, or I'm not an expert on SIBO or anything. So there might be resources and experts out there that are like, FODMAPs, here's why, these are the foods, and they know how to do it. Personally speaking, what I do, there's a handout on one of these next pages that's paleo FODMAP combined. I'll have them go paleo for a period of time, gluten, dairy free, sugar, corn, alcohol, soy, all of those. And then some foods, they know when it bothers them. There's one SIBO person I'm working with now, won't touch garlic or Brussels sprouts. Fine, don't. If you know that they're a problem, don't. Or I'll have them, sometimes what I will have them do for the significantly symptomatic is eliminate all of the red and the yellow for like a week, according to this chart, for like a week, and then introduce them and see if they're bothersome. Yeah.
Where did you find this chart? Did you make it, or did you find it somewhere?
No, it was on, it was like a year and a half ago that I found it. I don't remember the source. It was something online though.
Okay.
Is where I found it. References. Yeah, for sure. And I liked how that one was organized too. Yeah. So have them introduce it slowly. And if they don't have any symptoms, if they don't notice that, that's also the beauty of SIBO too, is you'll notice symptoms within about half an hour of eating. It's usually pretty fast because it's in the small intestines. So if they don't notice anything, then go about eating the food accordingly. But the paleo, low anti-inflammatory, low glycemic, kick out grains, kick out legumes, things along those lines. But these individual foods can be kind of tricky with FODMAPs. And you can still make gains independent of, not following a FODMAP style diet. Okay, intermittent fasting and the migrating motor complex. I'm going to touch on this because we're running out of time, and I think there's a class after this. Intermittent fasting is one of the best ways to stimulate the migrating motor complex. Not only are you restricting food, so there's less of a presence, there's less antigens for the immune system to go after, there's less food to feed the bacteria. I mean, that's intuitive. But it also gives the digestive tract a rest, like the gallbladder, the pancreas, the stomach. And then more importantly, it activates that migrating motor complex. So it will help not only starve the bacteria, but then propel that cellular debris, the dead bacteria, the food byproducts, so it can be cleared out. I love intermittent fasting for that. And you'll notice most people with SIBO, it affects their appetite too. So most people with SIBO don't really want to eat. They have a hard time with that. So they have no problem with intermittent fasting, in other words, also. Intermittent fasting involves eating within a restricted time frame. So there's a few different mechanisms, ways by which you can engage in intermittent fasting. You can either fast for a full 24 hours or 36 hours, or just eat within an 8-hour time period during the day, 8 to 10 hour time period during the day, and then fast overnight. So you end up fasting for 14 to 16 hours, ideally 16, but kind of anywhere in that scope. Yeah.
For a longer fast, like 24 to 36, could you do like a bone broth fast as opposed to like just water? Or?
Yeah, that's usually what I'll do, is some kind of, if you suspect they have histamine issues, I wouldn't do bone broth. But outside of that, like teas, healing teas, ginger, aloe tea.
So basically just like no protein or whatever. So like, could you do like teas or coffees with like MCT oil?
Mm-hmm.
Just if you were like kind of starving.
Yeah. Coconut oil would be fine. Yeah, definitely. Teas, liquid fast, in other words, not necessarily just water. Yeah, absolutely. Yeah, good question. I give a class on intermittent fasting. This is a huge topic. So I give a class on that, and NTI is actually, we're in the process, we've already recorded it. So we're going to release that through NTI too. So stay tuned on that, because there's a lot of therapeutic benefits for intermittent fasting, and a couple people have been to that class, and it's a great topic. But to wrap up with the supplements, I do want to get on that protocol and kind of things to consider with supplements. So these are specific for like dysbiosis, I'll say, SIBO dysbiosis. That Metagenics Candibactin AR/BR protocol, what that is you take, those are specific products, Candibactin AR and Candibactin BR. Metagenics is a nutraceutical company. And what the protocol is you take 2 AR and 2 BR in the morning without food, twice a day. Typically in the morning without food, and then mid-afternoon without food. Then use the biofilm disruptors. I like Clear Labs Interface Plus or Designs for Health and acetylcysteine. I'll do 2 Interface Plus and just 1 N-acetylcysteine. Whenever you take the Candibactin AR and BR, so take them all together. Digestive enzymes with meals and hydrochloric acid support, whether that be betaine HCl or apple cider vinegar, or bitters. That kind of all goes together. You have to support detoxification during any kind of antimicrobial regimen, because these bugs are going to die and release a lot of toxic byproducts that you absorb. So you have to support your body in ridding those. And I would usually support the inflammatory response also in some way. You can add in some mucosal support, like aloe, marshmallow, kind of those mucinogenic herbs, just to help soothe the intestinal lining.
What about chia seeds? You know how they turn into a gel when you put them in water?
Yeah. Honestly, I don't know. I don't know if that different. They look mucousy, but it's not mucinogenic. That I'm aware of. And I would be concerned that the fiber might be a problem for people that are dealing with this. Yeah, that might be a problem, or feed the bacteria. Honestly, don't know. And then, yeah, the detox support, like I mentioned. And then also, you know, if they have nutrient deficiencies, address that. If they have autoimmune issues, you can address that. But this is for 30 to 45 days based on symptoms. Usually, you know, if they're clearing up by 30 days and you're like, I feel great, then you can start to transition. If they're like, I'm okay, but I feel like I could get a little bit better, then go for 45. From there, you replenish the gut and you start to heal the gut. So there's a compounding protocol with that too. Oh, no, thanks. It's Metagenics. Ultra GI Replenish is a medical food shake. 2 scoops in the morning and 2 scoops at night. And then throughout this process, that's for a month. And then throughout this process, I would use like a Saccharomyces boulardii or the spore type plant-based probiotics away from the Candibactins. All right.
So is this also a candida? Why are they called Candibactin?
I don't know where the name came from at all, but I use it with any kind of overgrowth, honestly. Yeah, so I use it with Candida too. Yeah, for sure. All right, guys, that covers it. Thank you so much for your time and patience. We'll probably look at expanding these classes to 2 hours. But thank you, and I hope that was valuable. Let me know if you have any questions. Don't hesitate to email, or if you want to take me up on the offer at the beginning of class. All right, thanks.
Thank you.